So I'd just like to welcome everybody to this Health Services Research Association of Australia and New Zealand webinar. The aim of the association is to provide networking, education and training and to build capacity in health services research in Australia and New Zealand. We try and run at least one webinar a month on health service policy and methodology topics. The webinars are 3, but we do encourage people joining the webinars to have a look at our website and our membership arrangements and to think about joining the association. The association also runs a biennial conference. The next one is being held this November on the Gold Coast, and the theme is Shifting Priorities, Balancing Acute and Primary Care Services. Registrations are open and early bird registrations close on the 30th of September, and there's a significant discount for HSR members to attend the conference. We also run annual awards and prizes, and we have a call out at the moment for Distinguished Investigator Awards and the Best HSR Papers of 2017, and those nominations close on the 31st of July. So again, have a look at our website and think about putting in a nomination for somebody in the profession who deserves recognition. We also run an emerging researchers group and an Indigenous researchers group, issue a regular bulletin with news events and career opportunities, and we have a great mentoring scheme as well. So as I say, please take a look at our website. Couple of housekeeping issues. As I said earlier, all delegates should be able to see all the slides and our headshots and hear everything that's being said, but we can't hear or see you. But you can chat with us using the chat button at the bottom of your screen. If you move your mouse around, you should see that. And if you have any questions for Zach, if you type them in the Q&A, use the Q&A button at the bottom of the screen and type them in, what we'll do is we'll run through those at the end of Zach's presentation. And I'll pass over to Rachel Morton, who's on the executive team of the Health Services Research Association, and she'll do the introductions. Thank you.
Terrific. Thanks very much, Sarah. Hello, everybody. My name is Rachel Morton. I'm the Director of Health Economics at the NHMRC Clinical Trials Centre at the University of Sydney. And it's a great pleasure to welcome our presenter today, Associate Professor Zachary Munn. Zachary is the Director of Transfer Science at the Joanna Briggs Institute and Director of JBI Adelaide Grade Centre. And he's going to be presenting to us on an introduction to the grade approach in systematic reviews and guideline development. He'll talk for about 40 to 45 minutes, and then we'll have 15 minutes for questions and answers. Thanks very much, Zachary.
Great, thank you, Rachel, and thank you, Sarah, for the invitation to speak to you all today. Very passionate about grade and grade methods and the use of grade in systematic reviews and guideline development. So so I jumped at the opportunity to be able to present this webinar to you all today. Grade is a very large methodological approach. So today it will just be an introduction to using grade, but if you are interested in using grade, I hope you do get in contact with me following this webinar so we can keep discussing it. So just quickly, some declarations of interest. I am an employee of the Joanna Briggs Institute at the University of Adelaide, a member of the grade working group. I have some editorial roles, but I don't have any financial conflicts of interests. And if you do have any questions following this webinar, please contact me at my email address, zacharymunn@adelaide.edu.au. So the purpose of this webinar today is to just give you an introduction to the grade working group and to really explain why the grade working group even exists. How did they come to be and where are they now, and what is the actual grade approach to assessing certainty of the evidence? Because it is just a short webinar, at the end of this talk, I will be pointing you in the direction of some further resources that you can use as you start applying grade methods. And hopefully we'll have a chance to answer some of your questions as well. So let's start off right at the beginning with an introduction to grade. So who are grade, and why were they formed? Well, grade was an informal working group which was formed in 2000, largely based in McMaster University in Canada. And for those of you who are familiar with evidence-based medicine and evidence-based healthcare, the university, McMaster University, will ring a bell for you all. This is sometimes considered the birthplace or cradle of evidence-based healthcare. And of course is where David Sackett and Gordon Guyatt and others who are fundamental in coining the term evidence-based medicine and developing methods in evidence-based healthcare have worked. So it started out as this informal collaboration of researchers and guideline developers who are really interested in methodology and how we can actually rank or grade the evidence and establish our trust, our confidence, or our certainty in the evidence, and particularly the results of evidence, and how we can move from that evidence to actually making decisions and recommendations in trustworthy clinical guidelines. So the purpose of a grade working group is to come up with a system for grading the quality or the certainty of the evidence and the strength of recommendations that is transparent and sensible. And there's a link to the grade website here, and there are a lot of great resources on that website, including additional YouTube presentations and handbooks. Now, since their informal beginnings in 2000, the grade working group has grown quite rapidly, really. And now over 100 organisations from 19 countries have formally endorsed the use of grade and grade methods in systematic reviews, guideline development and health technology assessment. And you can see here some of the organisations that have endorsed the use of grade, and it really is becoming the international standard for developing trustworthy clinical guidelines to inform practice. A little bit closer to home now, and in Australia, both the Joanna Briggs Institute and the Cochrane organisation both explicitly endorse the use of grade methods and require grade methods in their systematic reviews. And when it comes to guidelines, recently the NHMRC have endorsed the use of grade as a preferred development methodology for developing clinical practice guidelines. And here in Australia in 2016, the NHMRC released their standards for guidelines. And you'll see that some of these standards explicitly relate or are in line with the grade approach as well. Particularly this standard here, standard 6, that all guidelines will be evidence informed. They will be informed by well-conducted systematic reviews. And within these systematic reviews, the body of evidence for each outcome, including the quality of that evidence and other factors that influence the process of making recommendations, including benefits and harms, values and preferences, resource use and acceptability, are all considered. And this is really in line with the grade approach. And also here in Australia and in South Australia, we have the first grade centre in Australia and New Zealand, which is situated here in Adelaide, the JBI Adelaide Grade Centre. And what our centre tries to do is to really encourage people to start using grade and to promote the uptake of grade methods amongst systematic reviewers and guideline developers. And not to just promote the use of grade, but also to support people with using grade and act as a central hub for grade methods here in Australia. So if anyone is interested in grade, or if you have questions about grade and using grade or want to know more, please do let me know. Or you can visit our centre website here at the link. So that's a brief introduction to the history of grade, but why do we use grade? Why is grade important? Well, let's take a step back in time now and talk about some of the initial approaches to developing clinical guidelines to inform practice. And some of you may have heard of the GOBSAT method, which was traditionally the original approach to developing clinical guidelines. And this approach stands for good old boys sat around the table. And basically what this approach to clinical guidelines was that eminent people or experts in the field would meet, would discuss, and then come up with recommendations, mainly based on their experience, to inform clinical practice. And this was the traditional approach to developing clinical guidelines. Not really evidence-based medicine. You might say it was eminence-based medicine. Now, we know that this approach isn't acceptable. We know that experts aren't necessarily always right, and that expert opinion needs to be balanced with what the evidence says. So a response to the GOBSAT approach was to start using levels of evidence and grades of recommendation. So levels of evidence have been used historically to designate different study types, and particularly to rank different study types based on their internal validity or their risk of bias. And traditionally you would see systematic reviews and randomized controlled trials as level 1, and then you would go down these levels to your other studies and your observational studies, etc. Once you had your levels of evidence, you also had grades of recommendation, and these grades would be applied to recommendations made in clinical guidelines to represent how much strength or how strong those recommendations were, and whether or not they should all be applied in practice. So levels of evidence were first proposed in the 1970s in Canada by the Canadian Task Force on Preventative Healthcare, and it was really revolutionary to come up with this hierarchy of evidence, and it provided a great way to be able to look at evidence, sort and filter a body of evidence and literature to give you some indication of how much trust you could place into that evidence and really help you sort it. But as time went on, we started to realize that it is not just the level of evidence or not just the study design that we are interested in, and that there are other factors we need to consider when we are talking about how much trust or how much certainty we can place into results of research. And what happened is people started trying to adapt these hierarchies or these levels of evidence with different elements, and a lot of people started to develop their own systems. And one of the big problems with these with some of these older levels of evidence is that the grades of recommendation were explicitly linked to a certain level of evidence, which means that you could never have a high grade or a strong recommendation based on any other type of evidence other than meta-analyses or randomized controlled trials. And in cases, this could lead to recommendations such as this, where a grade B recommendation has been assigned to smoking should be discouraged, basically because there were no randomized controlled trials on smoking. So we know that this approach isn't the best. It isn't really correct, that we should be directly linking the grade of recommendation only with the level of evidence. We know that we should be considering other things. So what the different guideline groups or professional associations started to do was develop and adapt their levels of evidence. And then start considering other things, like in this example, where you have your level 1A, where it talks about methodological quality of the studies as well, not just necessarily their design. You can see in a level 2B how they talk about low quality RCTs with less than 80% follow-up. And what you started to see were these increasingly complex levels of evidence systems where they are trying to incorporate other aspects into their levels, not just based on study design, and a real proliferation of all of these various systems to classify the evidence, where you started to have different levels from 1 to 4, 1 to 5, with 1A, 1B, 1C, and different recommendations as well. You'd have some people would have just 2 levels of recommendation, grade A and grade B. Others would have grade A, B, C, and D. And it got to the point, or it is at the point where for those of us who use clinical guidelines, you might not always remember if a grade B recommendation means you should definitely apply it, or if it actually means it's a weak recommendation. because there are just so many different systems in place. There was no standardization in this field. So some of the first work that the grade working group actually did was to look at some of the various systems that have been developed to establish the quality of the evidence and the strength of recommendations. And this is a paper published in 2004, which is basically a critique of some of the current approaches, or some of the current, in 2004 anyway, approaches to establishing the strength of recommendations and applying a level of evidence. And from this work, and from a lot of meetings and a lot of discussions and a lot of methodological investigation, GRADE have now come up with an approach which is becoming the international standard. And the GRADE approach to coming up with recommendations is that when you are making recommendations for practice in a clinical guideline, in a trustworthy clinical guideline, then you need to consider not only the level of evidence, but all of these aspects. You need to consider the balance between benefits, harms, and burdens. You need to consider patients' values and preferences and any equity concerns from a population perspective, resource use and feasibility as well. And balancing all of these considerations is the certainty of the evidence. But how do we determine the certainty of the evidence, and what do we actually mean by certainty of the evidence? Well, when we talk about the certainty of the evidence, we're talking about how much trust or how much confidence we can place in the actual results of research, or what the results of the evidence, in the results of the evidence. And a key principle of GRADE is that we can simply communicate the results of research and how much certainty we have in these results. So it's not about just presenting the final odds ratio or relative risk, but also saying how much we can actually trust this. And there's a little cartoon here of two meteorologists working in a weather bureau. And one of the meteorologists says to the other, I figure there's a 40% chance of showers. This could be considered the estimate of effect, or the effect size, or the results. And then he says, and a 10% chance we know what we're talking about. And this 10% chance that they know what they're talking about is what we mean by certainty or quality, or how much trust we can actually place in the results of research. So that leads us to the question, how do we establish our certainty in the evidence? And if it's not simply by study design, not only by the level of evidence, how can we ascertain the quality of the evidence, and what actually impacts our confidence regarding the evidence? So what should we be considering when we try to come up with this ranking of certainty? And if you look here at this example meta-analysis and looking at the results, what do you think would impact your confidence in these results, or your certainty in these results? Well, this was one of the first activities that the GRADE working group embarked on as well. And after much discussion, they came up with 5 factors or domains that can affect our certainty in the results of research. First off, methodological limitations or the risk of bias of the studies. If there are methodological limitations in the studies that we are including, this may decrease our certainty in the results. Indirectness, so if the research isn't actually directly answering the question that we have in our clinical guideline, this is a form of indirectness and may reduce our certainty. Inconsistency or heterogeneity, if there is wide variation across the body of evidence, across the studies that we've included, this can also reduce our certainty. If there is imprecision in the effect estimate or the effect sizes, this can also reduce our certainty. And if we suspect that publication bias is present, this can also affect how much certainty or how much trust or confidence we put into results of research. And there are some factors that can actually increase our confidence or our certainty in the results of research as well. So if we see evidence of a large, consistent or precise effect, this may increase how much trust or confidence or our level of certainty. If all the plausible biases are actually underestimating the true effect, this can also affect our certainty. And if there is a clear dose-response effect as well. Okay, so they are the factors that the grade group came up with, and I want to discuss some of these in a little bit more detail with you during this webinar. But the first, one of the first principles to get across to you is how does this ranking system actually work? So the grade approach is that there are four levels or four. Our certainty of evidence ranges from high, moderate, low to very low. And when we have evidence that is coming from a body of literature that contains RCTs, so randomized controlled trials, then this evidence is starting off as high. We have high certainty at the beginning. Then we need to apply and apply all of the grade factors or domains, and we can actually downgrade that evidence then based on each area of concern. So if there are issues with the risk of bias or methodological limitations in the trials included, then we can go from having high certainty to moderate certainty and so on. Now, observational studies, a body of evidence containing observational studies, due to issues with confounding and other limitations of those observational studies, a body of evidence that comes in from these study types starts off as low, not high, and can then be downgraded as well. Okay, so this is how it looks. You have your body of evidence, and for RCTs, you start off as high, and then you consider downgrading based on those 5 factors or domains I've briefly introduced you to. And then for non-randomized studies or observational studies, you apply the factors for upgrading and consider if any of those are relevant. And what do we actually mean by this high, moderate, low, and very low quality or certainty? Well, the grade handbook explains this in a bit more detail, but for high quality means we are confident that the true effect lies close to the estimate of the effect. For moderate quality, we are moderately confident in the effect estimate and that the true effect is likely to be close to the estimate of the effect, but there is a possibility that it's substantially different. If we only have low quality, then our confidence in the effect estimate is limited. The true effect may be substantially different from the estimate of the effect. And where we rank it as very low quality, we have very little confidence in the effect estimate. And there's actually been a recent paper this year that discusses our levels of certainty in a bit more detail. So let's go into these factors that can decrease our certainty a little bit more in depth. So the first one is methodological limitations, and many of you will be familiar with this if you've been involved in systematic reviews or clinical guidelines. Synonyms for methodological limitations are looking at the risk of bias or your critical appraisal, or sometimes it's called quality assessment as well. So if our studies that we include in our systematic review or our clinical guideline have a high risk of bias, then we may consider downgrading, and many of you will be familiar with the Cochrane risk of bias tool, which addresses most of these domains. And we know, so what we are really looking at here in this risk of bias assessment for randomized controlled trials, when a body of evidence is randomized controlled trials, is if there is any risk of selection bias, or performance bias, detection bias, attrition bias, or reporting bias. So practically, what we need to do is assess the risk of bias for each study, providing data for an outcome. And then we need to use tools appropriate to the question and study design. So for randomized controlled trials, we use a Cochrane risk of bias tool. For non-randomized studies, we might use the Robbins I tool, the new Cochrane risk of bias tool for non-randomised studies, or there are other scales such as the Newcastle-Ottawa scale as well, which we might consider. I won't delve into it today, but you can use the grade approach for when you're doing a systematic review of diagnostic test accuracy, and if this is the case, you can use the QUADAS tool. And for prognostic studies as well, you can use a QUIPS tool. But once you've finished this critical appraisal or your risk of bias assessment, you then need to consider whether you have any concerns in the evidence. If you have no concerns based on the results of this risk of bias assessment, then you don't need to downgrade. Essentially, the evidence stays as that high certainty for now. If you do have a serious concern, you'll need to consider downgrading of one level. And when you have a very serious concern, if you are very worried about the risk of bias present in the studies included, then you should consider downgrading by 2 levels. So we'll move on now to the inconsistency of results, or unexplained heterogeneity. And this is where there is widely differing estimates of treatment effect across the body of evidence or across the studies that you've included in your systematic review. Now, if inconsistency exists, we should always look for an explanation and see if there are actually true differences in the population group, whether there are true differences in the intervention and how it's being administered, whether there are true differences in the comparator, or true differences in the outcome and how the outcomes are being measured. Now, where there is unexplained inconsistency, you may lower the quality of or lower your certainty in the results of research. Now, how do we identify heterogeneity? Well, this can be determined by visually inspecting a forest plot, if we have a forest plot, and looking at the wide variance of point estimates. Are the results of the studies all over the place? Are they scattered all over the place? We can see if there is minimal or even no overlap of the confidence intervals on our forest plot. And we can look at some statistical tests as well, such as the Cochrane Q test and the I-squared statistic as well. So here's an example forest plot here. So here we have our meta-analysis of a number of studies. If you just look at this visually, you can see that there is only minimal overlap of the confidence intervals for each of these studies. Of course, we have our point estimates, which are the squares, the blue squares, and then the confidence intervals extending. And if there is only minimal or no overlap, this is an indication that there may be serious inconsistency or heterogeneity. We also look at the results of statistical tests as well. So here we can see we have an I-squared of 86%, which is quite a high I-squared. Obviously, I-squared is a percentage ranging from 0 to 100%, and 86% would be a cause for some concern. And our test, our Cochrane Q or standard chi-squared, is statistically significant as well. So in this case, we would be concerned about the inconsistency of the studies if we were doing a systematic review. I'll move on now to indirectness of the evidence. So when we have direct evidence directly compares the interventions which you are interested in delivered to the populations in which you are interested in and measures the outcomes that are important to patients. Now, when we do a systematic review, we're obviously going to try to find evidence that meets our inclusion criteria and only include that evidence and answer the question that we're asking. However, if we're doing a clinical guideline, sometimes we may need to rely on evidence from other populations or infer or make some infer from other studies that might not so clearly answer our question. And the way that we assessed indirectness is looking at the applicability of the results. So other populations or interventions studied, those you're interested in. So for example, you may be creating a clinical practice guideline looking at pregnant women. but the only evidence that exists comes from all women, not those who specifically are pregnant. And this can represent a form of indirectness in some circumstances. Other forms of indirectness include where there may be surrogate outcomes, so outcomes that aren't necessarily patient-important outcomes, often things like lab tests, which may actually be surrogates for more patient-important outcomes, such as mortality, or where there's been indirect comparisons as well, so where you're interested in the head-to-head comparison of, say, two interventions, but unfortunately, both of those interventions have only ever been compared against a placebo. And then this is a form of indirect comparison if you're interested in actually the two interventions and their effectiveness against each other, not against a placebo. The next factor is imprecision. And this is where we are faced with imprecise results, and an indicator or some indicators for imprecision. We can look at the confidence intervals and whether they are quite wide or whether they are quite precise. This is the first thing that we should be looking at. We can also look at whether or not there are only a few events presented in our meta-analysis as well, because obviously this has an effect on the width of the confidence intervals. And if there is a small sample size across the studies that we are including for that outcome. And one thing we need to consider is what we call the optimal information size. And essentially what the optimal information size is it says that if we are doing a systematic review that includes a number of studies, then the overall sample included in our systematic review should be at least equal to an adequately powered randomized controlled trial. So an adequately powered randomized controlled trial, which has done a power analysis or a sample size equation to make sure that they can actually determine statistically significant results. So it makes sense that if we are doing a meta-analysis, we want to make sure the sample size in our meta-analysis is at least equal to what would an adequately powered randomized controlled trial. Now, imprecision it can be quite complex, so I would like to refer you to the grade handbook and grade publications for more details. And it's important to note here that imprecision particularly is considered different for systematic reviews as compared to guidelines. And for those, and in fact the whole grade approach, there are differences whether you're coming from the perspective of doing a systematic review or whether you are coming from a perspective of performing a clinical guideline. So there are nuances. The main reason that imprecision is different is that guidelines have been contextualized for decision making and recommendations, whereas systematic reviews are normally free of this context. So when we do a clinical guideline, we're more concerned, perhaps not necessarily about that central line of no effect that we see in our meta-analyses, but minimally important thresholds or thresholds that are important for clinical decision making. So here we have an example forest plot, and we're coming from an uncontextualized point of view here, say in our systematic reviews, and immediately what we can see is that although there is a reasonable number of events, this probably doesn't meet our optimal information size, and we have quite a wide confidence interval. And we discuss issues with imprecision a lot more in a lot more detail if you're interested in some of the workshops that we run for grade. Now, the next factor and the final factor for downgrading our certainty in the evidence is publication bias. And many of you will be aware publication occurs when we might suspect publication bias if there is a lack of, if we generate a funnel plot such as the one shown on this slide, which shows that it looks like some of the smaller negative studies or no effect studies haven't actually been published. We know that publication bias is a serious threat to the validity of systematic reviews and meta-analyses. Systematic reviews should be based on all the evidence. And if some studies aren't being published, this is a serious cause of concern. We should suspect publication bias when only we find from the small studies, we're only finding positive studies from the small studies. If the studies that we're finding have only been published by for-profit interests or pharmaceutical companies, for example. And we do have methods to evaluate publication bias, such as presenting these funnel plots, but it is these aren't necessarily perfect, and there are statistical tests as well to formally evaluate asymmetry in these funnel plots, but you need to meet a minimum number of studies to be included in these funnel plots for them to have any power. So they are the factors that raise quality, and it's a bit of a that decrease quality or certainty. And I quickly want to zoom through the factors that can raise equality. So observational studies, a body of evidence is initially ranked as low, but can be rated up. However, before we do this, we need to consider the factors for reducing the quality of evidence before we consider the 3 factors for rating it up. And we should only be rating up evidence when they should only be made when there aren't serious limitations in the 5 areas for reducing the quality of evidence. So the first one is a large magnitude of an effect. So what we're saying here is that even though observational studies are subject to confounding and may therefore overestimate the effect, if there is such a very large effect and a very large and consistent and precise effect, then we have more trust that is actually representative of the truth. And there are some rule of thumbs about what is a large effect. So, for example, a relative risk of 2 can be considered large, a relative risk of 5 can be considered very large. And if we look at the example of babies sleeping on their stomachs compared to sleeping on their backs and their risk of developing SIDS, we know that there's an odds ratio of 4.1. So quite a large effect there. So we may upgrade 1 level for large or 2 for very large. Now we might have, the next factor is a dose response gradient, and a dose response gradient is one of the factors that is indicative of a cause-effect relationship. And one of the things that Bradford Hill talked about as indicative of a cause-effect relationship. So if there is a clear dose response between the intervention and the outcome, or the administration, increased administration of an intervention and the outcome, we may have more trust in that evidence. So some classic examples are warfarin and bleeding. We know that as we increase the dose of warfarin, the risk of bleeding becomes greater. Conversely, we know that every hour we delay in providing antibiotics for those who have sepsis, that this increases the chance of mortality. And similarly, we know that every hour we delay in removing indwelling urinary catheters, we increase the risk of developing a urinary tract infection.
Zach, just to let you know, you've got about five minutes or so left.
Fantastic, thank you, Rachel. So I'll quickly zoom through the rest of the presentation now, so we have some chance. We have a chance for some questions. The final factor for upgrading is a little bit more complex, and it's often quite fun to talk through when we do our workshops. But basically, what this last factor considers is where there may be confounders that are actually underestimating the effect or underestimating the true effect. So a good observational study will try to address confounders or adjust for confounders in their results. However, you can't always identify all the confounders because you may not actually know what they all are. So this is what we're interested in here, the residual confounding confounders that haven't been addressed in the analysis. And in cases, this residual confounding may actually be working to reduce the effect. However, we're still seeing an effect. And if in these cases we are still seeing an effect but we suspect that the confounders should be actually underestimating the effect, we may place more trust or may be able to increase our certainty in those results. So for example, if sicker patients are actually doing better in one group, that might actually improve our certainty. Okay, so they are the factors that we need to consider, and the end result of a grade process for systematic reviews is a summary of findings table. And these summary of findings tables or evidence profiles basically summarize the results of a body of the results or information of a body of evidence, including the level of certainty. So here's an example evidence profile, and here we can see this is an evidence profile for antibiotics for children with acute otitis media. And you can see here how many studies were included for each outcome, what the results of the applying the grade factors, and whether there was any serious concerns or not. Then we see the results presented in both the relative results and an absolute presentation as well, and then a ranking also. This is an example of an evidence profile. More commonly in systematic reviews, we see a summary of findings table, and you can develop these summary of findings tables with the grade group software, GradePro GDT. And these are really designed to improve the accessibility of the results. So it presents illustrative comparative risks, and often it presents absolute results as well, along with a relative effect. Here's an example taken from a Cochrane review looking at probiotics as an adjunct to antibiotics for the prevention of pediatric antibiotic-associated diarrhea in children. And you can see that the information is presented in such a way that will help assist interpretation of the result. So you can see what the assumed risk is in the control group, those who aren't getting probiotics, that the incidence of diarrhea will be 223 per 1,000 children, whereas in the probiotic group, this is reduced to 89 per 1,000. And then if you go across a couple of columns, we can actually see the quality of the evidence from our grade ranking. And these tables often have footnotes that explain, or do have footnotes that explain how the grade ranking has come up. So just very quickly finishing up on actually making recommendations now. So guideline members need to weigh all the criteria that we discussed earlier when making their recommendations, along with the certainty of the evidence. And it's a great approach that there is essentially just two levels or two grades of recommendation, strong or weak, or sometimes we use conditional instead of the term weak. So we can have strong 4 or weak 4, as in a strong recommendation supporting the intervention, or a weak recommendation supporting the intervention, or a strong recommendation against using the recommendation, or a weak recommendation against using a recommendation. And here's a very nice table that just shows how patients, clinicians, and policymakers can interpret what a strong recommendation and what a weak recommendation actually mean. Now, some of the difficulties historically with guideline panels is that there's a lot of vigorous debate and discussion amongst the panel. Some people may be conflicted and may be interested in one of their own studies. And it can be very unclear sometimes how you move from the evidence to actually making a decision or recommendation. And that last image was just displays that sometimes organising or chairing a guideline panel is like herding cats. So to make it very clear how we actually move from the results or move from the evidence to actually making to the recommendation, the grade group have developed the evidence to decision framework, which can help structure discussion, make sure that all of the important factors for coming up with a recommendation have been considered and discussed by the guideline panel, and it makes it really clear to guideline users how the panel moved from what the evidence said to their actual recommendation. It also really facilitates other groups who may be interested in adapting or adopting the recommendations from a panel, for example, in a different jurisdiction. It makes it a lot clearer to see how they move from that evidence to those recommendations. And once again, you can develop evidence to decision frameworks within Grade Pro GDT. So just finishing up, so why should we actually use grade? Well, it is a transparent approach to rating certainty, and it's not just, doesn't just clearly present the results, but actually how much certainty we can place in those results. There is a clear separation between the certainty or level of evidence and the strength of recommendation, and other issues other than study design are considered. When using grade, we are focusing on the outcomes, not the study. So we're looking at all the evidence contributing to an outcome, not just on an individual study level. There is now very clear guidance on how to do this ranking and create recommendations. And it really is becoming the international standard for systematic reviews and guideline development. And I've really only just touched on grade today. Grade is actually a lot more than just a rating system. It really provides advice for the whole guideline development process. So I hope you've enjoyed the presentation today. I will just point you to some other resources that you can access. I didn't get a touch on diagnostic test accuracy systematic reviews today, but there is an approach developed by Grade for these types of reviews. There is an approach for qualitative evidence synthesis as well called SERQUAL, which you can look at. There is a handbook for grade. For those of you who are developing clinical guidelines, you might want to visit the Jim McMaster Guidelines Checklist, which is a very useful repository of resources for each step of the guideline development process. In addition to Grade Pro GDT, there is another software program called Magic App, which stands for Making Grade the Irresistible Choice in Guideline Development, which is a very good tool for developing clinical guidelines. And we also have run workshops here at JBI. So I'll finish there, and thank you all for coming today. And I do hope that you do contact me after this webinar, and that we can work together on using grade. So thank you.
Terrific. Thank you very much, Zach, for your presentation. And it was a great introduction and overview to grade. Now's the time for you to type in your Q&A if you haven't done so already. Zach, we have the first question is from Lisa Hopp, and she asks whether grade has had any discussion of looking at credibility of synthesized findings in reviews of experience, that is in qualitative reviews, or when studies or reviews of experience are integrated into a clinical practice guideline. So has grade had any discussion about looking at the credibility of reviews of experience?
Yeah, that's a really good question. So grade, so yes, there is a grade approach now for establishing certainty in the findings of qualitative research synthesis or qualitative systematic reviews. This is called SERQUAL, and I only briefly touched on that at the end of the presentation. But they definitely do, and they have a number of domains or factors that they consider which can decrease your certainty in the evidence. Yes.
Okay, and the next question from Marilyn McDonald is JBI using CONQUAL, so CONQUAL, or SERQUAL? I don't know what CONQUAL is, so maybe you want to expand on that for any other listeners.
Yeah, sure. So CONQUAL was an approach developed within JBI specifically for JBI systematic reviews. At the moment, JBI qualitative systematic reviews are using CONQUAL, and we're looking at using SERQUAL in meta-aggregative reviews, but we haven't actually done that methodological work as yet, so we're not making any recommendations just now for JBI qualitative reviews.
Right, okay, thank you. The next question from Joanna Holt, 2 questions. First, how can you assess publication bias when you don't know about the unpublished studies?
Yeah, that's a really good question, and it is very difficult to assess publication bias. And I think I mentioned it in the presentation. We should always suspect that there may be publication bias present. Now, first off, what we need to do when we do a systematic review is try to find unpublished studies. And so this means if we're doing a traditional review of effectiveness, looking at the effects of an intervention, we should be looking at trial registries, for example, to see if there have been trials that have been registered but were never published. And if they haven't been published, we should be contacting the authors or the people responsible for entry in a trial registry and trying to find that data. So first off, we must be doing everything we can to try to find the unpublished studies as well as the published studies.
What about, can I just add to that, Zach? What about if you're developing a guideline and you're wanting to know that you've got that you've read other people's systematic reviews? Should you be checking Prospero for prospectively registered systematic reviews?
Yes, definitely. So yes, you should always check if you are doing a guideline or interested in doing a systematic review. You can certainly check Prospero, which is a registry essentially of systematic review protocols, and a good way to identify systematic reviews.
And following on from Joanna's first question, is there a similar grading system for grey literature?
No. So you use the exact same system, no matter what the evidence is. So if it's it doesn't matter if it's published or unpublished, you should use the same system.
Okay. All right. So next question here from Robin Clark. Are grade summaries expected to be included in all manuscripts to Cochrane, JBI and the mainstream press? So grade summaries, is that summary of findings tables?
Yes, I think that's probably what it means. So yes, for Cochrane systematic reviews, we expect a summary of findings table for all of our reviews of effectiveness. For Cochrane reviews, it's one of the MESA standards, which is methodological expectations of their systematic reviews, that you do assess the grade criteria. So it is mandatory nowadays to use grade in JBI or Cochrane reviews.
Okay. The next question's from Rick Wachula. The system feels as though it works well with medication studies, which are a single precise intervention. But what about in complex interventions? Rick gets the sense that these will always be heavily downgraded. What are your thoughts on that?
That's a really good question, and it's often a misconception about grade that grade can only be used for randomised controlled trials of simple interventions or where you have a meta-analysis, for example. In fact, grade can be used for any intervention, complex or simple, whether there's a meta-analysis or not. And there is guidance for how to use a grade approach if you don't have meta-analysis, for example, but you only have narrative. So you can definitely use grade for simple or complex interventions. It's an interesting question. Sometimes complex interventions, it depends. If the complex interventions are evaluated in rigorous randomized controlled trials and there aren't necessarily methodological limitations, and there's no reason why they would be heavily downgraded. But what often happens is that complex interventions aren't evaluated in these trials. They might be in non-randomized studies or other types of studies where there are concerns that would impact our level of certainty. So I don't want to say they will always be heavily downgraded, but once again, you need to consider all of the grade factors and the body of evidence.
Okay. So I've got a question about moving from previous grading systems in guideline development in particular to formally using the grade process and the evidence to decision criteria for making recommendations. In the past, often guideline developers are volunteers, doing things outside of their usual day jobs. And people have expressed concern about the amount of time that this takes. Do you think that processes are better now and that people are a bit more educated in the grade process to enable this approach to be more widespread and feasible?
Yeah, that's a really good question. I think the awareness of grade is improving. I think it was a great step forward, and I commend the NHMRC for adopting this approach for clinical practice guidelines now. I think grade is a rigorous approach, and that you do need to do some reading and understanding of it. But once you do understand the grade approach, I think I think it's quite beautiful in how transparent it is, and that people can actually finally see how people are interpreting the research, what judgments they're making about research, and particularly moving from that evidence to those recommendations, which is just critical, because that was a piece which sometimes you just couldn't interpret. And I don't know if anyone on the call has ever tried to adapt a clinical guideline from another setting for your own setting, but sometimes the work in just trying to adapt a guideline, once you've done it properly, you pretty much just developed your own guideline once again, because there was this black box that you could never see. So I think I hope everyone starts using the grade approach, and I think it is definitely the international standard now. But when everyone is using it, it's going to be so much easier for people to be more efficient in guideline development, because there will be these standard summary of findings tables that can plug into these evidence to decision frameworks. You may be able to apply evidence to decision frameworks from other settings and then look at your setting and tinker with some of the elements. And I think there will be a lot of a reduction in redundancy, shall we say, as people start using this international standard.
Okay, just a final one or two quick questions. As a health economist, I've been involved in the evidence to decision components for the recommendations when studies of cost effectiveness are included in systematic reviews and need to be incorporated into guidelines. So there are three components of the evidence to decision process that involve cost effectiveness, and that's things like how large are the resource requirements, what's the certainty of evidence around the resource requirements, and does the cost effectiveness favour the intervention or the comparator. And on face value, they seem like they're quite easy and clear to answer, but I find there's very little guidance, for instance, on what large or moderate resource use is. And it's entirely dependent on the context, because what might be moderate resource use in Australia might be very large resource use in Fiji, for instance. So have you had much experience with those components, and do you know whether there'll be any additional guidance that really talks about what those categories actually mean?
Yeah, that's a really good question, and obviously resource use is so important when you're making recommendations. So the first thing the guideline panel needs to do is to decide what perspective they're making the recommendations from. Are they making it from a clinical perspective or from a population level perspective? And then your issues regarding resource use change, obviously. Recently, GRADE have also published guidance on making coverage decisions. And obviously this changes so much based on your population and perspective. Right. So whether you're in Papua New Guinea or in Australia, as you say. So yes, I didn't get into the details today, but like most of the elements of GRADE, the devil is in the detail, and that detail does exist. That was just an introduction today, but there is guidance for the differences between individual clinical perspective recommendations to population perspective recommendations to making coverage decisions as well, all tied to resource use, obviously.
Great, thanks very much, Zach. Zach, do you have any other final comments that you'd like to make before we bring this webinar to a close?
Just to thank you all again for attending. As you can see, we here at the JBI Adelaide GRADE Centre, we're very passionate about GRADE. We want to help you start using GRADE. So if you do have any questions, please let me know. Okay, excellent. So everybody knows that they are able to contact you by email and have your email address. I'd now like to bring the webinar to a close and to thank Zachary very much for his informative presentation and great responses to many of the questions that are starting to develop. And on behalf of the Health Services Research Association of Australia and New Zealand, thank you for participating, and hope to see some of you at the upcoming conference in November. Thanks very much.
Thanks, Rachel and Zach. Thank you.